Hey, BC here. Welcome to BC Nephro. Thanks for watching. Today I'm going to be talking about CRRT, Continuous Renal Replacement Therapy. For more information, check out the videos at this channel and check out the articles at bcnephro.com. Links to both will be in the description below. So let's get into it. CRRT, Continuous Renal Replacement Therapy. What is it and why is it used? So this is a form of continuous slow dialysis that is typically used in critically ill, hemodynamically unstable patients who cannot tolerate intermittent conventional hemodialysis. Although it has not been shown to have improved outcomes, improvement in mortality, or improvement in renal recovery, it is widely thought to be better hemodynamically tolerated, and it is definitely better at helping to maintain or achieve volume status, the desired volume status for these patients. So why is this? First of all, why do people get hypotense with dialysis? Hypotension is a common complication of dialysis. Why does this occur? There's three possible explanations. The first explanation has to do with blood is actually leaving the body. So when blood is passing through the hemodialysis circuit, it's leaving the body outside the intravascular space, and this can be a strain. It is a relatively low volume of blood that's outside of the body at any given period of time, about 150 to 250 cc's, and most patients can tolerate this. A similar volume is outside the body both during conventional hemodialysis and CRRT. So that's not the explanation why this is better tolerated. Second is a change in oncotic, intravascular oncotic pressure. So when an osmotically active substance such as urea is lowered quickly, there is a lag time from when the urea can redistribute from the intracellular to the extracellular space. This decreases the extracellular oncotic pressure. Fluid goes from the extracellular to the intracellular space to equalize this pressure, causing a transient decrease in intravascular volume and some intracellular swelling. Now, this is most common to occur in patients who are severely azotemic when they first initiate dialysis, and is associated with a syndrome called dialysis disequilibrium. For this reason, CRRT is the preferred dialysis modality in patients with intracranial hypertension. But this is not the main explanation for why CRRT is better hemodynamically tolerated and better at achieving volume status. The main reason has to do with ultrafiltration. Now, there's ultrafiltration with dialysis. Fluid is removed from the intravascular space, and there's a lag time from when fluid redistributes from the interstitial space back to the intravascular space. Now, typically, the body has neurohormonal mechanisms to help maintain blood pressure during this, but if the ultrafiltration rate is too quick, or if the patient is critically ill, let's say septic, these mechanisms can be overwhelmed, resulting in hypotension. Typically, for hemodialysis, the hourly ultrafiltration rate is somewhere in between 500 and 1,000 milliliters per hour. It is recommended to keep the ultrafiltration rate less than 13 ml per kilogram per hour long-term in chronic dialysis patients. So let's look at a typical critically ill patient with acute kidney injury requiring dialysis, requiring renal replacement therapy. First of all, this patient may already be volume overloaded. They likely had hypotension and were given a volume. They likely had been developing acute kidney injury of progressive severity for some period of time and may have been oliguric, so they're already volume overloaded. Second, they often have a high obligate fluid volume. They're likely to be on drips. They're likely to receive intravenous medications, antibiotics, riders, transfusions, nutrition, either TPN or enteral nutrition, and they can easily require 2 to 3 liters of volume daily. So if we look at a patient that's, let's say, requiring 2 liters of volume daily, that's 14 liters for the week. Now, if you do conventional dialysis, 4-hour treatments 3 days a week, you have to remove those 14 liters in 12 hours to just maintain euvolemia. This is not going to be possible. Even if you do daily dialysis, 7 days a week, 4-hour treatments, you're going to have to remove 500 cc's an hour to achieve a neutral fluid balance. And again, in many of these patients, that ultrafiltration rate is not going to be tolerated. Continuous renal replacement therapy, if it runs for 24 hours, you only need to set it at 83 cc's an hour to achieve a neutral balance, and you can go higher than this. Let's say if you're going up to 150 cc's an hour, you can make the patient negative. Slow continuous ultrafiltration is the main reason why CRRT is better tolerated and better able to achieve volume status in these patients. And if you made it this far, thanks for watching. Hit like, subscribe, let your friends know, and until next time,